Thanks everyone for these amazing presentations so far. I'm Rachel. Today I'm going to talk about something we don't think about often, how people live and die in homelessness, and how I might propose we use an equity-oriented palliative approach to care as a guerrilla advocacy, as Dr. Allison mentioned this morning. So I'm calling in today from the traditional lands of the Blackfoot Confederacy, the Métis Region 3, and the Dene people of the Tsuut'ina and the Nakota Nations on Treaty 7 territory in Calgary, Alberta. I want to acknowledge the ongoing and historical harms caused by the Indian Act, Canada's first prohibition policy. The harmful and continued effects of drug policy and colonization have created unjust systems of care. By focusing my public health and harm reduction nursing practice on systems and policies, I hope we can create equity-oriented programs that include people traditionally left out of the decision and planning processes to build more compassionate communities. My practicum placement was at the University of Victoria with the Palliative Approaches to Care and Aging and Community Health Research Team led by Dr. Kelly Sagitar and under the supervision of Ashley Mollison. My culminating report describes the process of creating an equity-oriented palliative approaches to care curriculum that will be used to build capacity among teams across Canada to improve equity and access to quality palliative care for structurally vulnerable groups, including those living with poverty, homelessness, housing precarity, the effects of colonialism, racialized, criminalized, or those using illicit drugs. And again, as Dr. Allison mentioned so eloquently this morning, the insignificant others. This team leads the way in research and resources for adapting palliative approaches to care to an equity context to meet the diverse and intersecting needs of people who face deficits in access and distribution to the social and structural determinants of health. For this presentation, I will focus on some of the findings from our environmental scan and critical review, which led to the outline of a 13-module curriculum. Before I get too far ahead of myself, I want to briefly define some key concepts, which I've tried to capture in this graphic. Palliative care is often thought of as the medical care that takes place within specialized hospital units or hospices to offer comfort as someone nears the end of life. A palliative approach to care moves the care a bit further upstream to incorporate facets of palliative care into other health settings like long-term care or home care. An equity-oriented palliative approach focuses further upstream still by including community health and housing settings into the palliative approach to promote dignity, autonomy, and quality of life for those with life-limiting or chronic conditions, but who may have a long time yet to live. An equity-oriented palliative approach highlights how the systemic privileging and devaluing of people based on housing status or substance use are embedded within our systems, institutions, and legislation, creating policies that pose barriers to accessing health services for some. Rather than placing palliative care and health promotion at opposite ends of a spectrum, public health palliative care is interdisciplinary care directed at the social, psychological, spiritual, and physical needs of a person facing a life-limiting illness. Access to palliative care that mitigates suffering is an issue of both public health and social justice. Palliative approaches to care in the context of inequity begin early in a relationship with social and health professionals and include community caregivers throughout the journey. Much like harm reduction interventions, our public health and human rights initiatives that reduce the negative consequences of substance use, a palliative approach to care consists of non-judgmental, practical interventions that promote wellness and enhance connection across the lifespan. So people who are structurally vulnerable are at greater risk of poor health outcomes and early death from late diagnosis of life-limiting conditions, progression of chronic illness, drug poisoning, and violence. The reasons for this, as many of my colleagues have mentioned, are not related to individual behaviors, but rather due to the barriers in access to health services and the intersecting social, systemic, and structural determinants of health. Equity-oriented palliative approaches address these determinants that make managing illness at any stage up to and including dying more comfortable while alleviating pain, stress, and suffering. For context, only 14% of people globally who would benefit from palliative care actually receive it. Homelessness in and of itself could be considered a life-limiting condition, as on average, people who experience homelessness have a life expectancy of about 2 decades lower than the average Canadian. 30% of the estimated 235,000 people accessing shelters in Canada are Indigenous, necessitating a tailored approach to improve equity, especially at the end of life. Because of the multiple barriers to accessing health services, the poorest of the poor and the most marginalized in our society die isolated in hospitals or alone in pain in shelters, encampments, or on the streets. Improving inequities in palliative care is an important first step in addressing overall health inequities for people and groups who are structurally vulnerable. This graphic attempts to capture the breadth of our work on this project over the course of my practicum. In collaboration with a steering committee made up of experts in social justice, lived experts, and health and social service providers, an environmental scan was conducted to collect and critically review existing palliative care curriculum addressing equity. 16 unique palliative care curricula met our inclusion criteria. For each of those, we reviewed the learning objectives to assess how equity was being addressed within the curriculum. Most of the courses reviewed targeted nurses and doctors to improve their skills in palliative care for mostly homogenous groups and placed the responsibility of improving equity within the realm of frontline providers and at the individual level. Some courses mentioned Indigenous cultural awareness, but do not go so far as to address cultural safety in a meaningful way. What we didn't see in the 16 curricula reviewed were courses targeting decision makers and management, or for settings other than hospitals or hospices. The equity concepts included mainly addressed adapting care to deal with language barriers, religious preferences, or racism, rather than addressing the power structures that created the inequities in the first place. Very little content addressed the impact of economic or structural barriers, and even fewer used an intersectional approach to vulnerability within the curriculum. Once the critical review was complete, it was clear there was a need for a curriculum that addresses equity-oriented palliative approaches to care for diverse learner groups, including leaders, decision and policymakers, and frontline staff from health, palliative care, harm reduction, and housing organizations, serving people facing intersections of oppression. Our team constructed outlines and learning objectives for a 13-module curriculum to be delivered in a hybrid modality of in-person, synchronous, and asynchronous delivery. 2 draft modules are complete and under review by Health Excellence Canada to be used to build capacity among 10 teams across Canada, working to improve equity in palliative care. This curriculum will be instrumental as it will include both conceptual theories and practical adaptations to improve access to palliative care for people with intersecting vulnerabilities who are most often marginalized from mainstream services. And this quote by Harvey Chachanoff, I think, describes why this is important. Thank you so much, and big shout out to my family who was on the call, and also all the instructors and faculty at the PSHP, as well as my colleagues and peers in the program.